Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for the first webinar in our special ABEP webinar series titled Military Cultural Competence, Providing Effective Assessment and Treatment. Today's webinar is being presented by Captain Kerry Kennedy, who is in the Medical Service Corps of the U.S. Navy and Assistant Professor of Psychiatry and Neurobehavioral Sciences at the University of Virginia. She is board certified in both clinical and police and public safety psychology and is a fellow of the National Academy of Neuropsychology and the American Psychological Association. Captain Kennedy has produced more than 70 publications in the areas of military psychology, aeromedical psychology, and neuropsychology. She is the author or editor of 6 books, which have been translated into 4 languages. We are very fortunate to have her with us today. We're looking very forward to Captain Kennedy's presentation. I know you're going to learn a lot from her over the next hour. I hope you all will join me in welcoming Captain Kennedy to our presentation. Captain Kennedy, it's all yours.
Thank you for that introduction, Dr. Martin. To all of you, good morning, afternoon, evening, or night, depending on where you are. For those in your pajamas, I salute you. Welcome, everyone. I am excited to speak to you today about military cultural competence. But before I do anything, I need to tell you that the views in this presentation are mine and do not necessarily reflect the official policy or position of the United States Navy, the Department of Defense, the US government, or any other institution with which I am affiliated. I also need to disclose to you my absolutely brilliant, definitely worth checking out conflicts of interest. I do receive royalties from book publishers on the topic of military psychology. And then finally, one housekeeping item. For anything I reference that I had a link for, the link is generally included on the relevant slide. For journal articles and other references, these are listed in the reference slides at the end of the presentation. So now we can get started. Your mission today, should you choose to accept it, is to be able to define military cultural competence, recognize at least 2 potential pitfalls for providers, and identify ways to develop military cultural competence. Note that this talk is very much an introduction, which I hope will stimulate dialogue, awareness, and interest. Yesterday, I gave this presentation to 2 colleagues for feedback because this is the first time I've given this particular talk, and they recommended that I define 2 words at the outset. Thus, I want to make sure we are all on the same page with how I use the words commander and instruction. For the purposes of this talk, commander refers to the senior officer who leads a military unit and who has legal and command authority over everyone in that unit. Note that I use the terms commander and commanding officer interchangeably. The term commander does get confusing because in 4 of the 8 uniformed military services, the Navy, Coast Guard, Public Health Service, and the National Oceanic and Atmospheric Administration Commissioned Officer Corps, commander refers to a specific rank, specifically an 05. Last, commander in this context will never refer to a member of a Washington, D.C. based professional football team. Next, instruction is the term for formal written military regulations. Department of Defense instructions must be adhered to by everyone working for or serving in the military. Anyone failing to comply is subject to flogging. Okay, maybe not flogging, but administrative action. So back to cultural competence. In 2008, Rieger and colleagues addressed military cultural competence by stating that the Army represents a discrete cultural group with unique features of language, manners, norms of behavior, and belief systems. Cultural competence, traditionally applied to the treatment of ethnic and racial minorities, is also essential for the ethical treatment of Army personnel. Obviously, Rieger was in the Army, but you can easily substitute Army here with military, and this statement will be equally true. Specifically, this competence refers to the ability to evaluate, treat, and make informed decisions for both service member patients and the organization in the context of rank, their specific job, whether they are officer or enlisted personnel, their branch of service, mission, military instructions, and military laws. When we review cases momentarily, you will see the impact of some of these cultural variables on the decision-making needed by the clinical psychologist. The US military represents its own culture as defined by the same variables that make up the framework of other cultures. The experience of serving forms identities, changes worldviews, instills specific belief systems, and makes service members a part of a large and meaningful entity. To truly discuss this slide would take a full semester, but to give you a sense of what I'm talking about, let's look briefly at one of these. Consider collective versus individualistic cultures. This slide shows a part of a military psychological health literacy campaign that depicts two ingrained collectivist military concepts and applies them to psychological health. These are for your viewing pleasure while I talk for a moment about the differences between American culture and American military culture. America is an individualistic culture, and as a general rule, a typical American is more likely to prioritize self over the group, and Americans value independence and autonomy. In contrast, the American military is necessarily collectivist, is a collectivist culture, which prioritizes group loyalty, common goals, supporting others, and prioritizing the needs of the group over the self. The Navy teaches you how to think about this through the mantra, ship, shipmate, self. The Navy leaves no room for confusion as to what your priorities are. Mission before anything, team before self. A self-focused view in the military cannot be tolerated because that kind of thinking literally gets people killed. For mental health providers, the fact that the military is a collectivist culture, while the society it serves and from which service members are recruited is not, is one of the leading causes of mental health appointments, leading us to potential pitfall number one. It is also notable that a large proportion of mental health providers treating service members are a part of the individualistic culture. This has the potential to create a serious disconnect between treatment recommendations and the service member patient's reality. Many people believe that the number one mental health diagnosis in the military is PTSD. That is untrue. The number one diagnosis seen by providers treating the military population is adjustment disorder. And this transition period from an individualistic culture to a collectivist one is the biggest reason for the most junior enlisted personnel to end up in a mental health provider's office. In addition to probably being the first time they are away from home, the newly enlisted service member is adjusting to loss of individuality, loss of freedom, and loss of privacy. And what does that look like clinically? It looks like a 19-year-old with potential depressive or anxiety symptoms telling you, I made a huge mistake. This isn't for me. I hate the Navy or Army or Air Force or Marine Corps or Coast Guard. And I'm honestly not sure if anyone hates the Space Force yet. It is important to know that the vast majority of young service members do successfully make this transition. It can be sped up by sending an expectation of a successful transition and active teaching of effective coping strategies. Just as you'll see adjustment disorders in junior service members adjusting to life when coming into the military, you'll see it in more senior people transitioning to veteran status when going out to the civilian world once their active service is complete. There is a lot more to be said about the collectivist nature of the military and its contrast to American society, but I hope that gives you a glimpse into one of the major differences between American culture and American military culture. I hope at this point that you believe the military is a unique culture. APA is coming around to that conclusion, and in the draft changes to the ethics code is adding veteran status to diversity paragraphs. This is a good first step, but it ignores the current military. Division 19 is lobbying to have that change to military and veteran status, and we'll see what happens. Ultimately, we'd like to see this expressly stated in the ethical standard on competence. Similar to the slide on the variables that make up the military culture, this slide on what mental health providers need to know and be able to do would likewise take a full semester to teach. We will touch on some of these in the course of the cases, but for now, let's focus on one aspect of one: rank. Rank describes and defines your place in the military. It reflects how long you've been in the military, what your duties are likely to be, how much personal freedom you are allotted, and whether or not you are directly responsible for other people. For enlisted troops, rank is expressed on a scale from E1 to E9, and for officers, O1 to O10. The people in this photo are all Navy Lieutenant Psychology interns, or O3s, living their best life on the deck of an aircraft carrier. So how can rank interface with your efficacy as a clinician? Let's start with a basic decision and potential pitfall number 2. What are you going to call your service member patient? Think about what rank is. Your rank becomes a primary identity. In the military, you aren't John or Carrie, except to your friends. You are PFC or Lance Corporal or HM2. Rank reflects your military affiliation and belonging. A military rank personifies strength and ability, and using it sends a strong message from the clinician that the service member has the ability to return to prior levels of functioning and return to duty. There is a good body of literature regarding the positive correlation of expectation of recovery and actual recovery. And in the case of service members, that equates to return to duty. Using rank is a powerful way to instill realistic expectations, take advantage of the internal power and strength that goes along with the military rank and identity, and doesn't risk infantilizing, especially junior service members. So let's change gears and talk briefly about professional standards for competence. In 2017, APA completely revised its cultural competence guidelines and published Multicultural Guidelines, an Ecological Approach to Context, Identity, and Intersectionality. This document doesn't directly address the military, but it can be applied to the military culture. It is comprised of 10 guidelines, which are too many to cover in this introduction, but I did want to highlight one of them to demonstrate the practical application of our field's multicultural practice guidelines to the military culture. I do recommend that you read all of the guidelines. The reference for them is in the reference slides. As an example, the 10th guideline emphasizes a strength-based approach in order to build resilience and decrease trauma, and operates from a perspective that acknowledges challenges while also identifying positive ways in which diverse individuals, families, groups, communities, and organizations address life experiences. The military can be thought of as a group, a community, an organization, and for many, a kind of family. Experiences in the military are many. Some are amazing. Service members do get to have adventures and travel the world. And then there are associated hazards, experiencing active combat being one of these. Guideline 10 is easily applied to the conceptualization of these combat stress reactions. There is a substantial difference between military or occupational trauma versus victim-based trauma, the latter of which is what our diagnostic system and treatment guidelines are based on. And if we are to approach service members from a strength-based position, we need to work from the empirically based occupational model. Very briefly, this is what the model looks like. In the occupational model, trauma is expected. It typically occurs to a group or a team as opposed to an individual. It comprises continuous stressors and potential traumas, and service members actively train and prepare for them. When events occur, training kicks in, and assuming good training, service members go on autopilot to do what they need to do. In the occupational model, symptoms associated with stress reactions occur prior to any trauma occurring. Hypervigilance and sleep disruption, as examples, are present in those in active combat zones prior to and independent of anything happening. The symptom pattern is also different for those who do experience combat trauma and encompass underlying themes of grief, guilt, second guessing of performance, and risk-taking. Military mental health care better aligns with this model, which is more empowering of service members in care, doesn't ignore the role of the organizational context in treatment, and leads to better outcomes. For those who are interested, I highly recommend this book chapter by Castro and Adler on conceptualizing military trauma as an occupational hazard. That is also in your reference slides. So on the topic of clinical outcome, let's do a case. So this is a neuropsychology case. You have a 26-year-old male United States Marine Corps sergeant whose military occupational specialty or job is 0811 or artilleryman. He has 8 years of continuous active duty service and has been in the combat zone for 1 month. His medical and mental health history is remarkable only for 2 mild sports concussions in high school. He is a high school graduate with an AFQT of 94. Some of you might be thinking, what is an AFQT of 94? So let's take a military cultural tangent. The AFQT, or Armed Forces Qualification Test, is a composite score taken from the Armed Services Vocational Aptitude Battery, or ASVAB. The ASVAB is an aptitude test taken by every aspiring enlisted service member, and the AFQT score correlates at about 0.9 with full-scale IQ. So essentially, you have an IQ score on every enlisted service member you see, which means that you have a very good estimate of premorbid intellectual functioning. One caveat: all of the services use the AFQT as the standard for accession into the military. However, for actual job assignment, the various services rely on different scores. So if you ask a sailor for their ASVAB score, they will likely give you an AFQT. If you ask a soldier for their ASVAB score, they will likely give you a GT. Make sure you know which one they are giving you, because the AFQT is a percentile and the GT is a standard score with a mean of 100 and a standard deviation of 20. Because there seems to be a myth that service members are frequently low ability, be aware that even the lowest intellectual accession standard is in the low average range. Notably, the Coast Guard has the highest IQ standard and will only take people of average intelligence and above. Getting back to our sergeant, he has an AFQT of 94, which equates to the superior range of intellectual functioning. On this particular day, he was mounted, meaning he was traveling in a vehicle, specifically a mine-resistant, ambush-protected all-terrain vehicle, or a MAT-V. This is a photo of a MAT-V with a mine roller attached to the front. The duty of the mine roller is to trigger an IED and take the brunt of the blast, protecting the service members in the vehicle. However, insurgents adapted to our mine rollers by placing timing mechanisms on some IEDs so that it was timed to explode under the vehicle. In his case, his vehicle took a direct hit from a 50-pound IED. He was wearing his seatbelt, his flak jacket, and his Kevlar helmet. He was not wearing hearing protection. On the scene, a corpsman administered the Military Acute Concussion Evaluation, or the MACE. The MACE is a very quick field concussion assessment administered by enlisted medics and corpsmen. His was in the normal range for his cognitive score, which is represented by the 27 out of a possible 30. But he was red for neurologic score, which means the field neurologic exam showed at least one neurologic symptom, and the Bravo indicates that he is complaining of concussive symptoms. He was diagnosed with a grade 3 concussion, which means that he lost consciousness briefly. He also experienced 5 minutes of post-traumatic amnesia. He was airback to the combat ER. When I evaluated him, he was exhibiting 8 out of 10 headache pain, photosensitivity, dizziness, balance problems, and tinnitus. Notably, he had no symptoms of an immediate combat stress reaction. And just a reminder, the lack of a stress reaction is the single largest variable and predictor of recovery from and return to duty post-concussion. Stronger than IQ, though IQ also has a significant impact on clinical outcome. Given his protective factors, he recovered very quickly, and both the neuropsychologist and the sports medicine physician agreed that his symptoms had resolved after 17 days, which included resolution of his neurologic symptoms. His mood and cognitive scores on the automated neuropsychological assessment metric, or the ANAM, were consistent with his pre-deployment testing, and his exertional testing did not result in return of symptoms. As a reminder, the ANAM is a 15 to 20 minute computerized cognitive test which was given to service members pre-deployment so that psychologists could give it in theater after blast concussions to monitor return of cognitive function. So, can he be returned to duty? He looks good, right? But obviously he can't, or he would not make a good case example. And this brings us to potential pitfall number 3, failing to appreciate the service member's specific job. The sergeant is an artilleryman, meaning he fires a howitzer, which is a gun so large it requires a crew of 9 Marines. With a 155 millimeter extended range guided artillery shell called Excalibur, he can place the shell on a house-sized target 25 to 35 miles away. To understand whether or not he can be returned to duty, you need to understand the requirements of his job, and in this case, his weapon system. Let's take a moment to look at this photo, because everyone in this photo is unidentifiable. I will tell you that he provided this to me, and this is his crew. This photo is actually a video still, taken of a video of them firing the weapon, and you can see it was just fired. You can get a sense of the blast overpressure by taking a look at the ground, where you can see the impact on the earth created by the firing of the howitzer, represented by the raised, lighter colored earth. The blast overpressure presents a problem. In a recently concussed individual, repetitive subconcussive blasts to the vulnerable brain can result in the return of neurocognitive and other concussive sequelae. For this sergeant, further time away from subconcussive impacts in order not to disrupt his recovery is necessary. Further damage may be caused by returning him to duty too early. One final thought related to this case: no one in the military in any role understands all of the jobs. He gave me much of my education on howitzers, to include showing me that video during his concussion assessment, and that enabled me to do the research that I needed to do to inform the concussion team on what the risks were if he returned to duty at 17 days. Service members don't expect their mental health providers to understand exactly what they do, but they are a primary source for your education and awareness so that you are able to integrate what they do into your assessment and disposition. So let's do another case. This time you have a 30-year-old male Navy chief, cryptologic technician with a top secret security clearance. As a chief, he leads and is responsible for a significant number of other military personnel. On this day, he walks into his primary care provider's office in significant distress due to his wife leaving him just a few hours ago, simultaneously learning of multiple infidelities. She wiped out all of the financial accounts that she could, and she moved all of their furniture out of the apartment and left with the kids. His heightening level of agitation and anger concerns the primary care physician who facilitates an urgent mental health appointment. The mental health evaluation finds that the chief is angry, distraught, impulsive, in disbelief, agitated, and with urges and plans to go and confront his wife. He is not overtly threatening his wife, but he owns multiple firearms and has a concealed carry permit. He denies suicidal ideation, and he has no mental health history. The psychologist he sees tries to diffuse his extreme level of emotion. However, this is mostly unsuccessful, and he continues to perseverate on confronting his wife. His thought processes during the interaction are not entirely logical, and he continues to exhibit significant anger. Herein lies your dilemma. he doesn't meet criteria for a mental health disorder. But given the extreme events of the day, you consider his distress as a normative reaction. On the other hand, you have serious concerns about his current decision-making, anger, impulsivity, and potential for a bad outcome. So what do? Step one is to remember that you don't have to manage this situation from a clinical standpoint alone. Federal law allows for some disclosures to military commanders when there are concerns about the mental state of a service member. This law covers all providers, not just military providers. Okay, great. But is this one of the times that information may be legally disclosed? As with most things in the military, there's an instruction for that. Mental health providers are to adopt the stance that interactions are not to be disclosed, except in certain circumstances. These circumstances are harm to self, which does not seem to be a factor here, harm to others. There are concerns about this, though he has made no overt threats against his wife. Harm to mission. Let's table harm to mission for a moment. Special personnel. He does not meet the criteria for special personnel as outlined in the instruction. Inpatient care is not applicable. Acute medical conditions interfering with duty is not applicable. Substance abuse treatment is not applicable. And this evaluation was not a command-directed evaluation, but the result of a medical referral from his primary care provider. So this is also not applicable. But let's talk about harm to mission. In this case, you should disclose if you believe there is a serious risk of harm to a specific military operational mission. Such serious risk may include problems that significantly impact impulsivity, insight, reliability, and judgment. In this precise moment, all of these concerns apply to the chief. And recall that disclosure of information, whether mishandled accidentally or provided nefariously, classified at the top secret level, can cause grave damage to national security, and the chief has a top secret security clearance, routine access to classified information and material, and oversight of a significant amount of personnel with the same level of security clearance. Because of the clearance, you need to ask yourself, does the chief have a condition that could impair his or her judgment, reliability, or trustworthiness? Note that in security clearance lingo, a condition refers to any circumstance that raises concerns about stability, judgment, reliability, or trustworthiness. Condition used in this manner does not refer to a formal mental health diagnosis. Okay, so you've decided there is a potential risk to his wife, as well as a risk of harm to mission in the chief's current state. What do you tell the command, and who specifically do you tell? In a nutshell, you are permitted to notify the commanding officer or a person who has been formally designated by the commanding officer to receive protected health information, to include mental health information. So what did the psychologist do? This slide depicts the goals and intentions of what the psychologist and commander worked on together. I will now talk about what it looked like step by step. So first, the psychologist did what psychologists do, and she scheduled an outpatient appointment for the next day, and she notified the commander. She spoke to the commander about the day's events and concerns about agitation, impulse control, poor decision-making, and anger, and recommended that the chief not have current access to weapons or classified information until the crisis had passed. The commander removed his access to classified information by essentially assigning him to the tasks he needed to do to help take care of the situation, meaning time to consult an attorney, address the financial situation, buy some furniture, etc. The commander assigned another chief to pick him up from the psychologist's office. Given that the commander knew our chief, he chose a peer and known friend to assist him with the crisis. And our chief agreed for this chief to stay with him for a few days to provide support and to help guide his decision-making until he calmed down. Our chief gave his friend the key to his weapon safe and agreed to have all of his weapons locked up. Over the course of several days, our chief began thinking more rationally and returned to a functional state. His commander restored all of his privileges about a week later. Given his rapid resolution of symptoms, both the psychologist and the chief did not feel that any further mental health appointments were necessary, and they left it open if he felt he needed to return in the future. And that leads us to our last official pitfall of the day, which is having an insufficient understanding of relevant laws, military instructions, and command processes and resources to best support military patients, especially as it pertains to privacy and confidentiality. Federal law allows disclosures of mental health information when this information is needed by commanders. DoD outlines when information should not be disclosed and when it meets the threshold for disclosure. The command has a high degree of resources that can be used to assist service members in maintaining mental health, but only when they are aware of what they need. The chief's outcome was optimal because his command was involved. Some of you may currently be contemplating your level of discomfort in communicating mental health information to a military command. I'm a psychologist, I get that. But keep in mind that keeping things from a command can place your patient, their fellow service members, and even civilians at risk. We are all trained to a degree of lethality that befits our roles. This is admittedly a wide range, but every person you encounter in the military has weapons training, probable weapons privileges, and many are in positions to make decisions about others that can have life or death consequences. In this one slide alone, you can see some of this range of routine responsibilities, from airmen building bombs in the top left, to naval air crews conducting helo operations somewhere in the Pacific Ocean in the top right, to National Guardsmen having to do riot control in the middle left, to coasties apprehending drug smugglers in the middle right, to soldiers learning how to manage an active combat situation in the bottom left, and to people you assume should have no weapons responsibilities whatsoever in the bottom right. And make no mistake, medical personnel with weapons are one of the most dangerous things that you will encounter in the military. Just to clarify, that last was mostly a joke. With that in mind, service members understand that because of the nature of their job, which they voluntarily signed up for, that much of their medical information is not 100% private. Upon entry into the military, and at least once per year, we are all reminded of this and sign this statement as a part of our routine health assessments. To keep a medical or mental health condition that could interfere with military duties from the command is a violation of a military instruction, and service members not adhering to instructions can be administratively separated from the military. Now, communicating with the command brings a number of challenges, and it is both art and science. Here are a few tips but the attached link provides more, plus links to a number of important instructions related to military privacy and confidentiality. First and foremost, don't give out any information that isn't needed by the command. For example, developmental histories are certainly pertinent for your assessment, but they are almost never needed by the command. Give the command what they need to make informed decisions, but no extra. Also, don't give the command a copy of your written report. Decide who to call. Most mental health providers default to calling the commander. While this is okay, the commander may be the least useful person to start with. Unless the command is very small, the commander may not personally know the service member in question, resulting in your input being conveyed down the chain to the designated action officer. Granted, as we discussed previously, the commander is the one you are permitted to call due to privacy laws and policies pertaining to confidentiality. So have a conversation with your service member patient, discuss the information that needs to be passed, discussed, or gathered, and let them tell you the person they are most comfortable with you contacting. You will need written permission to call anybody that is not the commander. And please note that this person needs to be someone who has some decisional authority in either the enlisted or the officer chain. Make a plan. What do you need to accomplish by contacting the command? Are you calling just to provide a simple update? For example, an active duty service member has been admitted to the hospital, or are you calling because you need information from the command to advocate for your service member patient or to problem solve for the patient? Figure out what you want to accomplish before you call. The last tip is to explain things directly, concisely, and without any psychology lingo, or the commander is put in the position of essentially translating what you said. In the case of the chief, the psychologist would have the most success by introducing the communication with something like, "Good afternoon, Captain Smith. My name is Dr. Jones. I'm a psychologist at the local clinic, and I just finished evaluating one of your chiefs. I have some concerns about him. His wife left him today and took all of their things and the kids and is having a very difficult time. He's not thinking straight, and I think there is a good chance he will go and try to find his wife, and I don't see that ending well." Obviously, there's more to say and to work out, but I think that gives you an idea of how to present information to a commander. And this approach avoids any misunderstanding, doesn't communicate that the CO needs to be concerned that his chief has a mental health problem while still keeping all parties safe, and eliminates complications related to his job status once the chief has managed this crisis stage. While it would be nice if there was no stigma related to seeing mental health in the military, this is not the current reality. Consequently, it is critical that unless you think your service member patient has a mental health disorder, that you not convey that they do to the command. This commander fully understands how devastating the day's events have been for the chief, but the commander will think differently if you describe it with a DSM-5 text revision code or diagnostic explanation. But this process doesn't always go smoothly. Recall the ANAM from the first example, the baseline cognitive testing given to everyone who deployed in support of the war in Afghanistan. This is a great example of how probable psychobabble was translated to military speak. These signs were plastered all over Camp Pendleton when I was there preparing to deploy to Afghanistan in 2010. I enjoyed my brain scan too, by the way. All right, so how do you establish military multicultural or military cultural competence? Well, we're psychologists, so read and take courses. It's what we do. The journal Military Psychology is 100% devoted to military psychology. Psychological Services is the journal for Division 18, Psychologists in Public Service. It devotes a lot of its space to veterans issues, and Military Medicine contains only medical to include mental health research specific to the military. Alpha Blog Charlie is my blog for Psychology Today. I publish a new military psychology topic about once a month. And the Center for Deployment Psychology has resources on their website, offers courses routinely, and even has a self-paced online course on military cultural competence. Keep up with military news as it pertains to mental health. The Early Bird Brief is a daily email, Monday through Friday, that provides a list of all military relevant news articles from the last 24 hours. There are almost always military mental health related articles. Social media can be used for good. The local commands where you practice almost always have a Facebook page. The main military specific news publications are also good to follow. Stars and Stripes and Military Times are examples. Note that each service has its own Military Times offshoot. So Navy Times, Army Times, etc. Establish consultation resources. The single best thing you can do is to join the Division 19 Facebook group. I'm completely serious. This group is restricted to psychologists and psychology students, and you can ask just about any question there and get help. It is comprised of about 1,600 active and civilian psychologists working all over the world and with all of the services. If you aren't sure what to do with a service member patient, this is a great place to start. Obviously, no identifying information. Division 19 also has a listserv, a Twitter account, the journal Military Psychology, a newsletter called The Military Psychologist, a website, APA convention programming, a psychology leadership program, a mentorship program, etc. Division 18 is the counterpart for Division 19, as its military focus is on veterans, while Division 19 is focused mostly on the active military. And if you are a civilian provider seeing referred service member patients out in town, call up the local military mental health clinic and meet the staff there. They will be an invaluable resource for you, and they will get a better idea of the best referrals to send to you. Finally, there is a lot of military relevant CE available. We've already talked about Divisions 18 and 19. You obviously already know about the webinar series offered by ABPP. The American Board for Police and Public Safety Psychology has an incredible online training series, almost all of which is relevant to military practice. I've mentioned the Center for Deployment Psychology, which is affiliated with the Uniformed Services, sorry about that, everyone, which is affiliated with the Uniformed Services University in Bethesda, Maryland. And last, there are a number of military-themed conferences. The Combat PTSD Conference is coming up in October, and the Military Psychology Summit is typically held in June. So thank you very much for your attention and participation today. I believe we now have a little time for questions.
That's correct. Captain Kennedy, thank you so much. There have been many comments in the Q&A box about how wonderful this is and how there are so many helpful comments that you've made. So thank you very much. And we do have several questions, so let's see what we can get covered. Towards the beginning of your presentation is where this question pertains. What are the benefits and potential costs of addressing a client by rank?
So I see mostly benefits. And again, rank is different for different ranks. And so I am so senior now, you can address me as anything and it really doesn't matter to my functioning. But if I was a junior person in therapy, rank is the safest thing to do. First, most of our junior people are going through something temporary. The adjustment to the military is a very common problem. Some people end up in a therapist's office, some don't. But those who do have the benefit of sort of speeding up that transition process. But it's hard because they do come in, they're genuinely miserable and upset, and and I hate the Navy is a very common refrain. But if you can help them work through that for a couple of weeks and instill expectation of success, then most of the time that occurs. If you refer to them by their civilian name that maybe mom calls them, you inject a subtle hint that this military thing doesn't need to happen. And yes, those 2 or 3 weeks of transition are going to be difficult for the person. Clinical judgment, right? You do need to decide if the person is suitable for returning to their command. But the long-term benefits of getting through that are huge. Not just the tangible ones, the educational benefits and everything that goes with serving your tour to the end, but also personally, quitting is a failure. And especially in men as they get older, those who have dropped out of the military or had to get out early for some reason have a lot of life regrets that really define them. And so there is a lot of harm that can be done by that, because I have it too, that instinctual, I want to save this person right now and make him or her stop suffering. But just be careful about that. These are young kids transitioning into a difficult situation. But most of them make it if you hang in there with them.
Great, thank you very much. Another question, when disclosing confidential information, would you let the patient service member be aware what steps you will take?
100% of the time. The only reason I could think to not would be if they were in a very serious psychotic episode or something where they just didn't understand. Mm-hmm. But I usually have the service member with me so that they know exactly what's going to happen. They tell me who to call if somebody has to be called. And a lot of times somebody doesn't have to be called, but it's in the service member's best interest if the command gets involved. But yes, 100% of the time, the service member is involved through the whole thing.
Great, great. And another question. So to be clear, there is no need for authorization to talk to their commander, but you do need authorization to speak to anyone else?
That is correct. Okay. As a general rule, that is correct. Now, if you have special personnel, like people with flight status, then you can always talk to their flight surgeon. But as a general rule, you only have permission to talk to the commander.
Okay, great. There was another question that I can actually answer, and that is, your rank is as captain. But we have one more question I think we can squeeze in. The question asker says, that was really informative. I appreciated your defining of terms as you went along. I'm curious how other factors of diversity impact someone. Seems like rank becomes the all-encompassing identity. How are factors like gender, sexual orientation, race, etc., acknowledged given the social hierarchy within the country and around the world?
Sure. So that is a very involved question. But I will say the military is probably the most integrated organization in the country already. And it's not just those sort of multicultural variables, but there's many, many, many subcultures in the military. So each service is a subculture, each job specialty becomes a subculture. So you have a lot of factors that work together. Now, obviously for, as a woman, I came in where there were rules, where there were jobs I was not allowed to have. And we've seen with other changes, the don't ask, don't tell is gone. The military is trying to sort of figure out how to integrate transgender with some of the other laws and things going on politically into the military. So those things are challenges,
Yes.
but I feel like they're not unattainable in the military. I do want to say one thing. The media depicts how we view everything, right? Or they cherry pick things. And so just be really careful about over interpreting things like violence in veterans or racism. I'm not saying those things don't exist, but they certainly are not massively pervasive.
Thank you very, very much. I wish we had more time to answer more of the questions, but thank you for what you did provide us, and the slides have great resources on them. So thank you very, very much.
You're welcome. I enjoyed it.
We were glad to have you with us.